Good afternoon, everyone. Today being the last day, last session, we will have a discussion regarding the EDOF and multifocal IOLs and regarding the various aspects covering the pre-op, intra-op and post-operative, as well as what are the various IOL options available. So first I would like to introduce our speakers. We have Jairam sir, who is a senior consultant in cataract, cornea and refractive surgery from Precise Trivandrum. Then we have esteemed invited guest speakers, Dr. Krishna Prasad sir, who is the head of cataract and refractive services from Prasad Netralaya Udupi, and he was the previous past president KSOS and currently the AOS editor proceedings. So I would like to invite him, Dr. Krishna Prasad sir, and also our Dr. Diksha Rani from Mumbai. She is cataract and refractive surgery from in Mumbai. So and myself, Dr. Navarosh from Precise Eye Hospital, Trivandrum. So first I would start with my presentation. I would like to invite the Diksha. So good afternoon, everyone. So I will be basically talking regarding the what all things you need to like keep in mind while for the preoperative evaluation in a patient we are planning for multifocal and EDOF IOLs. So as you all know, cataract surgery has evolved from evolved to refractive cataract surgery with patient. There is a shift in goal from mere visual restoration to spectacle independence and emmetropia. And with the help of advanced IOLs, we were able to do it to an extent actually. So why this multifocal IOL success starts before surgery? Because first thing is the pre-operative evaluation, patient selection is very critical, and even with advanced diagnostics, the predicting post-operative satisfaction remain complex. So we need to keep in mind all these aspects. What are the patient expectations? We need to be very all the measurements and assessments should be spot on, and also we need to properly counsel the patient regarding the adaptation. So main and important thing is the history. That is, we need to have adequate chair time with the patient before planning or before going for the premium IOLs. So we need to assess what are the patient, what are the visual goals, and what is the profession of the patient, what type of personality the patient is. We need to actually assess the person as a whole, not just looking into the eyes, but we need to assess the person as a whole. And we need to give realistic counseling. We should not tell like, if you put this lens, you will get everything, near, intermediate, distant vision, everything. You need to counsel the patient accordingly. And lastly, identify the poor candidates, and we need to rule them out. So we need to counsel the patient regarding the neuro adaptation, which is very important and critical in patients planning for multifocal IOLs. And studies have shown that bilateral implantation within short time frame often improves the adaptation success. These are the side effects most commonly which can be there post-operatively in patients with multifocal. So next step is detecting and addressing the pre-existing ocular surface conditions. So this is one of the most important thing which we need to keep in mind, because untreated OSD can lead to poor visual quality and refractive surprises, compromising on the surgical outcome. So if you put an IOL, multifocal IOL in a patient with ocular surface disease, it would be like rebuilding the engine but driving with a muddy windshield. So always evaluate for it and rule out severe dry eye disease, and if it is there, better to not to go with multifocal IOL. So proper preoperative screening and aggressive treatment for optimizing the ocular health and patient education is of prior importance. So tear film instability and hyperosmolarity can result in variable K readings leading to refractive surprises, which can be catastrophic in patients of multifocal IOL. And visual fluctuations caused by dry eye disease create perception that they attribute everything to the IOL. So you need to counsel them properly, and we need to treat the dry eye disease and the ocular surface condition before. And this is just to highlight the point that perioperative cyclosporin therapy actually helps in better visual outcome, as well as the better like a contrast sensitivity and all will be better. So next step is accurate biometry and IOL power calculation. As you all know, optical biometry is one of the main main thing which you need to do for a patient planning for IOL, for multifocal IOL. So there are wide variety of optical biometers available. The current or latest being the SWEPSO society. If you have access to it, very well and good. We will all, this is the two main SWEPSO OCT based biometry, being one being Argos and one being IOL Master 700. So all the measurements will be very accurate, and so in order to prevent any post-operative surprises. And astigmatism, it's a silent vision disturber, because we need to like if the patient is having pre-op astigmatism, even low values of 0.5 diopter need to be like corrected with either with toric IOLs or with LRIs. You need to correct it, otherwise you will end up in trouble, patient being dissatisfied in spite of putting the multifocal IOL. It may not serve the purpose. So all these latest biometers and devices measure both the anterior and posterior corneal astigmatism, leading to very less errors. IOL power calculation formula is very important in terms we need to use latest generation formula like Virgin formula, which incorporates multiple variables and to predict the ELP. And apart from that, we have newer ray tracing aberrometry formulae, AI based formula and is also available. Coming to the aspect of post refractive surgery, these patients will be demanding for multifocal IOL because they actually want spectacle independent. That is why they did refractive surgery. So we have a misconception in mind that they are always unsuitable for multifocal IOL, but I would say they are a wide variety of diverse group, and some of them actually can achieve excellent outcomes with the multifocal IOL. We need to document, however, minimal corneal higher order aberration, regular corneal surface, and absence of irregular corneal astigmatism before implanting multifocal IOL, but always better to avoid in post RK patients. And with latest refractive surgery machines, they leave the corneas with lesser aberrations post-operatively. And in case of myopic LASIK, being the main chunk of refractive surgery patients, they actually have positive spherical aberration in the cornea post-refractive surgery. So better to go for aspheric or negative aspheric IOLs, multifocal IOLs, which can actually compensate for this. And Barrett's-Rouquet formula is one of the good formula, and this is another ASCRS online calculator which has simplified the life of all surgeons. It is just free of cost. You can just multiple modules being available, and they give an minimum, maximum, and average IOL power at the end. It is just, I'll show the screenshot. This is how it looks like. You can just enter the basic details. If you have the pre-refractive surgery keratometry and other details, you can enter that also. And finally, they will give something like this. They will use multiple IOL power calculation formula to give average IOL power, minimum and maximum power. So we can choose the IOL power for the patient accordingly. Angle kappa is something which we usually look for the before planning multifocal IOL. Multiple studies have shown that, and they have showed that if it is more than 0.5 or 0.8, better to avoid the multifocal IOL. But there is another school of thought showing that recently that the clinical utility of angle kappa as a rigid exclusion criteria for multifocal IOL is not correct actually. They say that and studies have found that patient satisfaction studies have failed to find a strong and consistent correlation with the between angle kappa magnitude and the reported patient dissatisfaction or photic phenomena. So just excluding that only on the basis of angle kappa is also not very correct. That's their thought process. So, and we need to look for the pupil. It should be perfectly round and well centered for for this multifocal IOL perfect outcomes actually. So studies have shown that if the photopic people should be less than 3.5 and mesopic less than 5 mm for the better results. As you all know, capsular back stability is one of the most important thing. A perfectly centered multifocal IOL centration happens only in a stable capsular back. Any instability, let it be like pseudo exfoliation, PCTS, anything can lead to decentration and loss of multifocal IOL outcome. Higher order aberration is something which you need to look into, especially post refractive surgeries and all. The patients can have higher order aberration, so we need to evaluate. This is a machine, iTrace machine, which actually look into it. There is no real guidelines for the cutoff, but review suggests, literature reviews recommends less than 0.3 micrometer. Actually, you can proceed with the multifocal IOL. And always, it is like very basic thing which you need to evaluate the OCT macula, the optic head abnormalities, everything you need to look into actually. And last point, based on that is the role of ASOCT, even though limited in special circumstances in posterior polar cataracts or intumescent cataract, it actually can help in planning. Just going through the last 2 to 3 case examples. This was a 40-year-old patient who was an IT professional, complained of glare and difficulty in night driving. On examination, he was having posterior subcapsular cataract. Even though he was having BCV of N66 and N6 with glasses, he was very much having these glare issues and other problems. So we did biometry and we implanted VVT IOL in left eye. But later on the patient was not happy because when we looked into it, he was having a pre-op cylinder of 0.79. So in multifocal IOL, if we don't correct it, as I told earlier, it can lead to, even if we do everything right, the patient may not be satisfied. So always keep in mind, if there is even the small amount of astigmatism, you need to correct it. Second case example, it was a case of a housewife who decided for spectacle independence. She was having near mature cataract in both eyes, but her personality was sort of very much like like everything. It was a sort of perfectionist like thing. So we actually, when we looked into, she was having went down to biometric readings. She was having little like calculation, angle kappa calculation was on the higher side. Even though it's not, we cannot take on one single this thing about and as a strict contraindication. But since considering the patient personality and all, we avoided the multifocal and we implanted with the monofocal plus IOL, and eventually she did well. She was having 6.6 N8 unaided. Last case is a case of post-LASIK patient who wished for the spectacle independence with minimal cataract actually. She was having best vision BCV of 6/6 both eyes. This was a topograph showing minimal changes, and when we looked into higher order aberration also, it was on the lower side. So we implanted both eye panoptics and eventually she did well. She was having unaided 6.6 N6 vision. Just wanted to highlighting the fact that not all cases of post-refractive surgery we need to avoid multifocal. This was that patient's ASOCT showing the corneal interface, that flap cut in the section. So that's all. Thank you. Next, I would like to.
Yeah, thank you, Dr. Navrosh. I think I request Jayaraman to just go to the podium for his presentation. Before that, a couple of discussion I want to know. See, one very important the point you had mentioned about in your presentation about the pupil size. Of course, in the pupil size, as you said, that less than 3.5 mm in mesopic and more than around up to less than 5 mm in the scotopic pupil. That is also very, very important. That's okay. 3G. Yeah, that is. But the one important point I just want to highlight here about the knowing the dominant eye is so important in all premium cases. See, always you should be that perfect, dead on with the dominant eye. You can play around with the non-dominant eye. See, people started talking about mix and match IOLs. So what we do in mix and match IOLs, actually the dominant eye, they put a monofocal, and the even non-dominant eye people have tried with the multifocal lens. Patients are happy. But you need to find out the exact which is the dominant eye. There are different tests to know dominant eye. If you know the dominant eye, I think your results are going to be best. Then you need not have to have a eye trace or any of the machines. Rather, if you think that okay, the mesopic pupil size is smaller, that is around less than 3, you put them multifocal, trifocal, any ring lens, patient is not going to have a glare and halos. The problem always happens with whenever there is a larger pupil size, then patient will have a glare and halos. These are the two things I think you highlight. I think we'll have a final in conclusion in the end of the discussion. I think my friend Jayaraman is going to talk about high stakes, high standard surgical precision for EDOF and multifocal. Over to you, Jayaraman.
Thank you, Navarush and KSOS for having me here. So I'll be talking here regarding surgical precision for EDOF and multifocal IOLs. As you can see here in the global IOL usage trend, the EDOF and multifocal IOLs are on the rise. So every cataract surgeon should be very well versed with the surgical nuances of implanting a multifocal or EDOF IOLs. So regarding the pre-op reference marking in toric IOLs, either you can use a image guided system or marking you can do on in the OR with patient upright to avoid cyclotorsion errors. And topical anesthesia is preferred for better fixation and less pressure and quicker recovery. If the patient is anxious or has tremor or poor cooperation, you can use peribulbar. And always communicate with the patient regarding the bright light, and you have to look into the light and be cooperative, and you can talk, then it will be very helpful. Then regarding the incision, clear corneal temporal incision is standard. A steep axis incision of 0.5, 0.75 without toric component will be good. And square self-sealing incision, target wound size around 2.2 to 2.4 to minimize astigmatism. And symmetric parasynthesis to reduce vector surprises. For multifocal IOLs, proper axis marking is absolutely critical. The single most important step is a perfect capsular axis. Target the size to 4.5 to 5, and 360 degree overlap always will help to reduce the tilt and decentration and minimize postoperative PCO and capsular phimosis, and it also improves the predictability. So while doing this rexis, it is very important to center it perfectly, perfect centration of the visual axis. You can use the Purkinje reflex rather than solely on the pupillary center. And practical method is to ask the patient to fixate and note the coaxial light reflex and center the axis around the point. And use trypan blue staining in white cataract or poor red reflex. Femtocapsulotomy, if it's available, it will be more precise. In small pupils, always use pupil expansion devices and never compromise on rexis centration size to avoid using a ring. So phacoemulsification, you can use all your normal technique, but to avoid pushing the nucleus excessive manipulation that stresses the zonules. Cortical cleanup should be thorough, and you should do a proper good posterior capsule polishing to avoid early PCO, which is critical in multifocal IOLs due to contrast sensitivity issues. Then in toric IOLs, you should align the IOL exactly on the axis, because 1 degree misalignment will cause around 3.3 loss of toric effect. 10 degree will cause almost 1/3 loss, and 30 degree will cause almost total nullification of the toric effect. So you put the lens and then do the viscoelastic cleaning by keeping around 10 to 20 degree short of the final axis, and then rotate it to the final axis using irrigation. So this is case in which you use the toric marker to align the lens to the final axis. In manual marking, you can always mark the axis and then rotate to that particular axis to get the best result. So IOL insertion, you choose the right cartridge and incision size to avoid wound stretch and induce astigmatism, and should properly place it in the capsular bag. Haptic position, confirm both haptics are within the bag and fully open. And after achieving perfect centration, after full unfolding cortex removal, check centration against Purkinje reflex and the limbus. If slight decentration is noted, rotate, slightly nudge the haptics to recenter the IOL for optimal visual alignment. So the OVD should be nicely removed. It can cause, if retained viscoelastic, can cause, if it is behind the IOL, it will cause unnecessary refractive surprises also. And when to avoid multifocals? If there is a posterior capsular rupture which is large, then you should avoid it. If there is extensive zonal dialysis or inadequate rexus support, preferred alternative is to use a monofocal IOL in the sulcus. Multifocal IOL is generally contraindicated in the sulcus due to tilt, pigment dispersion, and dysphotopsia. Femtosecond laser, if there is, you have it, it is gives highly reproducible rexus size and precise, accurate incisions for astigmatism control and enhance surgical precision. So wound closure, you hydrate the wound gently to avoid corneal edema and induce astigmatism. Check for the integrity of the wound and especially check the toric multifocal to be kept in the exact axis. So final intraoperative checklist will be the IOL centration. You should check with the Purkinje reflex. Chamber should be adequately tight, toric axis alignment, and anatomical integrity. So these are two cases. One is manual, another is with femto. As you can see here, the rexus centered on the Purkinje image. You can phaco. The anterior capsule also should be washed nicely to remove the residual lens capsule cells. OVD should be removed from behind the cell, behind the lens also. Wound is hydrated. So both flax and conventional phaco with MF IOL will give good results, but as you can see here, it will the flax will give more consistency in IOL centration and effect of tilt and aberrations. This is one case which is post-op, which had a decentration and dilated. Here you can see the asymmetry between the rexus margin and the IOL edge. And patient had 6-9 vision, but he had visual phenomena. So we did a rotation and realignment. As the patient was taken up after 1 month, so there was some adhesions. So we released the adhesions and rotated the IOL. And it is nicely centered. Post-operatively, his IOL was well centered and had 6/6 vision without any other issues. So the take-home points are good preoperative mark and well-centered 5 mm axis, meticulous attention to IOL insertion, centration, OVD management, and wound closure ensures optical outcomes. Technology enhances but never replaces surgical precision and clinical judgment. Thank you.
Thank you, Jaraman, for a precise view about the not only implanting the premium IOLs, but there are a lot of other matter, especially when you're implanting a premium IOL, you should be very much aware of that visco removal and all other visco removal, and also aligning the exactly the any of these toric IOLs in the exact axis is also much more important. So we'll just going ahead with the newer EDOFs and multifocal IOLs, which regimes is a supreme. We got Dr. Diksha Rani from Krishna Eye Center from Mumbai, and she'll be got a wide range of experience with the newer EDOFs and multifocal IOLs. Over to you, Diksha.
Thank you, sir. Good afternoon, everyone. Before beginning, I would like to thank Dr. Navarosh and Drishti 2025 for having me here. So I'll be talking about the newer EDOFs and multifocal IOLs. So as it has already been discussed that cataract surgery is nowadays not just improving or clearing the visual axis, but giving a refractive correction to the patients. Lifestyle expectations and the refractive targets are another thing which have added to the outcomes. So these premium IOLs, they empower us to customize the vision for each individual. So what is, in addition to correction of cataract, the second target we have is spectacle independence, which everyone expects, the patient as well as the surgeon. So there are certain components of the spectacle independence. The first is range of vision. There are certain formats where the distance vision should be absolutely crisp without glasses, and some even expect a correct intermediate and a near vision without glasses. Appropriate astigmatism control will again enhance the visual outcomes. Refractive outcomes, the margin of error has really reduced. Neither is it acceptable by the patient nor by the surgeon. And again, quality of vision and other unexpected photic phenomena which may reduce the quality of life have to be addressed. So premium lenses have been there for quite a while. There are certain generations into which we can now divide them, because now we have seen a long era of these lenses. These lenses began as bifocal IOLs, where the concept of bifocal spectacles gave an idea of using these lenses inside the eye. So these lenses were used, but then slowly trifocal IOLs again came into this game and are now more popular and quite commonly used. But over the last few years, the EDOFs IOLs are taking up. So I'll be discussing a brief optics of these lenses, how they actually work, so that we know what we are implanting in patients' eyes, and a little bit of clinical experience which I have got over last few years using these different lenses. So starting with the history, refractive multifocal IOLs were the first one. This is one of the IQ lenses, Re-Zoom, which was a refractive multifocal IOL. So this IOL has a central part which was for distance vision during daylight, and a rim around it for near vision in moderate to low light conditions. And again, we have alternating rings for distance and near vision for different pupil size depending upon the ambient light. So in these lenses, the pupil size has an important role. There is no blend between these zones. So the tendency of glare and halo was very common. And second thing was, these lenses were highly pupil dependent. So if patient's pupil does not dilate well in dim light, he would not be able to see near. If the pupil does not constrict in the daylight, he would not be able to see at distance that well. So patients often used pilocarpine at night, or a small drop of tropicacil in the daytime sometimes to adjust with these lenses. These lenses soon went out of focus, and then came diffractive multifocal IOLs. These lenses have been there for quite a while and are still one of the most commonly used lenses. So these diffractive IOLs have these diffractive gradings, or the steps on anterior or the posterior layer of the IOL depending upon the brand. So what do these diffractive rings do is they bend the light. So refraction, there's a optical phenomenon called refraction, which we all know, and diffraction is slightly different from that, where the light bends at the edge. So when suppose 100 lux of light is passing through a diffractive microstructure, around 80 lux of light will be focused at different points and 20 lux will be just lost. So this is the issue with the diffractive IOLs, which led to their disadvantages and issues that we are aware of. So diffractive grating, playing with these steps width and height, leads to developing different variants of the IOLs, different ads of the IOLs, bifocals and trifocals. So we'll just like to just understand a bit more about them. So the width of these steps determines the addition. If the steps are shorter, that would mean a higher addition like plus 3.75 or plus 4, and wider steps, they give a smaller addition. So there are certain brands which have, like Technis Multifocal has different variants, a low addition IOL, a high addition IOL. So in there, the difference is between the width of these steps. Then height of the steps determines the amount of energy that bends. So higher steps means more energy is bending, more of light is being focused at near. So typically, for example, if the 100% light is going, around 40% is bending for near and 40% is for distance. So the amount of light that bends is determined by the height of steps. So based on, on the same principle, the concept of apodized IOLs was introduced, like the Alcon Restore was an apodized IOL, where at the periphery, the height of the steps was reduced. So this is a Restore IOL. The peripheral steps were shorter, like this. So as the pupil dilated, there was less amount of energy which was giving near vision. So in low light, the focus was more towards distance vision. So these were the different changes that were being made by different companies. We had Ecolet design by Technis. We had then this quadrifocal technology by Panoptics, in which there were minor changes in this diffractive microstructure to give different outcomes. So this Panoptics IOL was based on a quadrifocal technology where there were different, you can see the geometry of the steps was such that there were 4 foci, but the 4th foci, which was at 120 centimeter, was redirected to give a better distance vision. So doing this, they reduced the amount of light wasted. So typically 88% of energy was utilized as compared to 80% in standard multifocal IOLs. But now again, Panoptics is coming up with the Panoptics Pro, which again has some new things which we'll soon come to know. Another IOL which is quite commonly used are Zeiss lenses. They have 809, which is the bifocal, and 839, which is the trifocal. So this 809 has a single addition of 3.75 diopters, but they claim to have a range of pseudo accommodation of approximately 5 diopters. They claim to give a functional intermediate vision, but practically few patients still feel difficulty with these lenses for intermediate vision for using laptops, and sometimes they do have to rely upon glasses for intermediate distance, while the near vision is good. 839 model of AT Lisa is a good trifocal lens, but again, because of the diffractive structure, glares and halo is a common problem. Then I would like to just touch upon this Technis synergy. So Technis had come up with a Symphony IOL, which was a diffractive EDOF lens. So this lens was, again had a depth of focus kind of wavefront, but the structure was diffractive. So in synergy, they combined that Symphony concept and the multifocal concept and brought this IOL where it was a multifocal with EDOF, promoting it as a continuous range of vision. Again, this was a diffractive lens, and the incidence of glare and halo proposed was less, but again, that is a highly subjective thing. Some patients complain of it even when everything is absolutely right. So this was a brief discussion of diffractive lenses. Now we come to a new component in these lenses, which is the enhancing the depth of focus. Okay, so in a monofocal lens, the entire light is focused at a one fixed point, usually predominantly designed for distance, and distance vision is good, whereas for near and intermediate, the image is blurred because of poor focus. However, in EDOF lens, what happens is the depth of focus is increased to give a better quality of vision at intermediate and sometimes even in the near vision. So understanding these lenses, like taking this example of Technis Eyhance, which is one of the very popular lenses, the monofocal lens has almost a uniform power all around with just aspheric design. So we know that this Technis monofocal is an aspheric lens. Eyehance has slight change on the posterior surface to enhance that depth of focus. So this hence gives a little bit of intermediate vision, and typically patients who get these IOL implanted do not need a 2.5 add for 33 centimeter, but usually +1 or +1.5 is the add that they usually accept. And most of the patients do read N10 or N8 unaided in a good lighted environment. Similarly, the Rayner EMV, which is another popular IOL in this category, again claims to give a depth of focus of 1.5 diopters. So these lenses are a very good candidate to try monovision, mini monovision or mini monovision, where you can slightly play with the refractive error in both the eyes, correcting the dominant eye for distance and inducing a small amount of refractive error in the non-dominant eye to help with intermediate and the near vision. Second good thing of these lenses is that their tolerance for residual refractive errors is very high. So if a monofocal patient has a residual 0.75, he would definitely need the IOL. Whereas an enhanced monofocal patient, if he has 0.75, he might still be 6 parts despite the refractive error. And even the tendency of adjusting to residual cylinders for these lenses is also high. But these lenses are not pure EDOF lenses. They have now begun to be called as advanced monofocal lenses, because pure EDOF contains something called Vivity, which has a wavefront shaping X-wave technology, and there are certain bumps on the IOL which bends the light to create this wavefront and give a slightly better near vision. Technis Pure C is another variant, newer one, in which there is a continuous power change on the posterior surface of IOL, which again gives a better near vision. And Lucidus EDOF is another one which is quite popular now. It has a central 6 millimeter normal monofocal surface and a small button of asphericity, which gives the intermediate and near vision. So just to conclude, these are few slides of eye trace of patients with different IOLs. So you can see the first block indicates the internal higher order aberration. So in Eyehance, it is almost close to zero. Very few internal aberrations are there. Whereas in Vivity, you can see the amount of coma and trefoil is really high. But still, most of the patients are happy with these IOLs because despite there is a lot of scattering happening inside, neuroadaptation usually takes care of it. So time and willing to adapt is a very important component behind happiness after these IOLs. So these are other lenses with Synergy and Restore. Here again, you can see there's a huge amount of internal higher order aberrations with these IOLs. So a small gist of what I have observed in the patients coming to our clinic over last 2 years. So in Vivity, almost 90% of the patients, 2/3 achieved N6, rest were N8 to N10, and 1/3 of the patients used +1 glasses. Same for Lucidus. Only 6% of patients used glasses for near. Again, the average power was +1. And even in Pure C, around 32% of the patients needed a +1 add. Whereas for advanced monofocal, most patients were N8 and N10, but still for prolonged reading, they needed 1.5 diopter glasses. So again, to end it, success of surgery lies in appropriate candidate selection, and pros and cons have to be explained to the patient really well. And one mantra is to under-promise and over-deliver, which always gives you a happy patient. Thank you.
Thank you, Diksha. Over to Krishna Prasad sir for last topic. Surgery is not over. Tackling the post-operative challenges.
Thank you, Navrosh, for me to include this wonderful IC. Probably this IC would have been in the premium time, then still would have been a much more useful to all the people across. I thank the entire KSOS for this opportunity. So just Diksha, we are just trying with this micro monovision with the Rayner EME it's fantastic results actually. It gives a kind of effect of how I have done 1,000+ patients for Presbyon in a laser refractive surgery. Almost EMV lens gives a similar kind of effect with the Presbyon effect. there are few of the lens we have been trying, just recently started Femtis lens. This is a Femtis lens from Lensar. Actually, these kind of these are a sort of EDOF accommodative lens which have to be clipped to the entry capsule, but very very expensive lenses. But it has to be combined only with the femtos. But these lenses no glare and halos, but patient will get N5 also 6.6 and N5. But the lens is very expensive. I think both the lens together itself is almost around 1.5 lakhs cost price to us. So that is why not been become popular because of its price. And also Rayner has come with one more spiral lens. It is gaining popular. There are some amount of glare and halos I have tried, but could able to succeed with the N6. So all these lenses probably we may require to, if they have to read from the distance. Can you fix for 10 minutes? Can you fix for 10 minutes? No, no, it's 6.26. No, but it will make noise, then I have to finish off. Okay. So, surgery is not over, tackling post-op challenges. I think Navrosh has been very much in detail. He had told about the clinical judgment, about you need to see the history. There is a history of amblyopia, pinhole vision. You need to look at the color vision and comorbidities like age-related macular degeneration, glaucoma. These are the patients you should never think about all these premium lenses. But these are the few investigations like eye trace and all really handful when you are doing a premium IOLs. Of course, as Jairam said, that pre-op consideration often we missed about to dry eye. We need to treat dry eye, then we should go about with the treatment of premium lenses. Look at the irregular cornea. So always, I think all premium patients, we have to do corneal topography. You have to do OCT, especially to know about epiretinal membrane or early ARMD. And when you're doing with a premium biometer, you will know even about the whether there is a subluxation or even I think subluxation, or even when you're going with the cataract also you'll know the lens thickness also. So this premium biometry, this biometry with this kind of tools always very much useful, especially whenever you are going for a premium practice, and it's not going to be wasted. So one or two word about already Navras told about the angle kappa. Again, angle kappa is more important when you're treating a hyperopic patients in a laser refractive surgery. So always you should look at the, of course, large angle kappa uh, patients, especially a decentration can happen if the angle kappa is more than 0.7 mm, then you should not put a multifocal. Again, as your study shows that it is not really correlate with the results. But more important in multifocal or premium lens is about the angle alpha, which is the angle between the optical axis and the visual axis. So, which is very important in multifocal lens. Always you should avoid, if the angle alpha is more than 0.6, we should avoid. Of course, these are the angle alpha workup. I am not going to talk, but as I said, that large angle alpha combined with the multifocal, normally patient will have a glare and halos. Then few of us been trying with the aberrometry workup also. At 4 mm pupil, 0.3 microns of higher order aberration will produce a blur similar to zero point 0.5 diopters of defocal. So which cannot be implanted. Few of the study shows that higher order aberration more than 0.7, coma which is greater than 0.5, trifoil more than 0.4, tetrafoil is more than 0.3, or fifth order aberration more than 0.2. These are the few conditions you should not think about the premium lenses. So today I'll be talking about early post-operative challenges. What are the problems you may have, how we should overcome. Of course, one TAS or endophthalmitis, nobody even thought about that. Normally TAS is seen within 12 to 24 hours with a corneal edema. You should always be aggressive with the anti-inflammatory therapy, and normally you should always should have a strict asepsis and instrument care also. Corneal edema, it can happen with the sometimes with a long surgery when you're operating with a grade 4 nucleus. It can be managed by hypertonic saline also, but always whenever depending upon the nucleus, always you should adjust your phaco emulsification, low energy phaco, careful visco use. I think is very very important, and also thorough OED removal in the end of the surgery, as Jairam said. These are the other challenges he had already told about PCO, cystoid macular edema, and refractive surprise. Post-capsular opacification can even depend, can one of the late complication you can see, but again depending upon the kind of IOL material or surgical technique. So, of course, as early as within a 1 month, a lot of my friends been doing NDAG capsulotomy. Uh, some of the studies shows that use of square edge hydrophobic lenses reduces the PCO, but still I can say that PCO it's a multifactorial. Cystoid macular edema, probably I think post-operative macular fluid accumulation due to the inflammation, typically 4 to 8 weeks after the cataract surgery. So you have to treat with the management with the topical non-steroidal anti-inflammatory drug with the steroids. Even in severe cases, we've been trying with the periocular and intravitreal therapy. So good prognosis, timely treatment is very important. So, refractive surprise probably it is a failure to achieve the intended post-operative refractive target. So, what will happen if you are having a refractive surprise? It may cause anisometropia. Sometimes it may have a dominant switch also. See, 85% of the should be always less than 1 diopters. So, 55% of the inpatient within 0.5 diopters of target spherical equivalent following a surgery. So now I will talk much about this refractive surprise because we've been, in spite of sometimes been having a optical biometer of good quality, still you may land with the refractive surprise. Sometimes some problem happen. So if it happens, always, as we know that accurate biometry is very important. Also, uh, selecting the proper IOL formula selection is also very important, so that to avoid the sometimes wrong lens implantation. So whenever you are having a refractory surprise, so always thorough refraction to the has to be done. Look for any tight corneal sutures, then see for whether lens has put in the sulcus or whether there is a subluxation. So sometimes what happens, the distended capsular bag, that is what Jerome was telling in this one. You should not leave the viscoelastic behind the lens. If you leave, sometimes it can cause a myopic shift also. So also you need to look for whether any the presence of corneal pathology, whether having a patient is having a corneal edema. That also sometimes influence the refractive outcome. Of course, sometimes post-operative cystoid macular edema also may have a hyperopic shift. So always when you're having this problem, always you should look at go back to the biometry where exactly the thing has happened. Then always look for check the axial length by repeating the biometry. Check for abnormal keratometry whether patient is having already pre-existing keratoconus. Sometimes there is no error, then we always attribute it to the something called a effective lens position, and ELP is so important. Effective lens position, it can happen in the other eye also. We have to be mentally prepared for that. So clinical management explain the error openly, and it is not an apology. It is not a declaration that you have done a mistake, but always you should tell the patient openly that this is some of the refractive error has been remained. Just to some of the patients started irritating, if there is nothing wrong in taking the second opinion. But the best option, if you are like in doing nothing, is always the best option, I can say. Many refractive surprise do not require any surgery at all. Sometimes what happens, if you leave behind some amount of low myopia, that may help them for near vision also. Some of the patients already wearing the glasses, they don't mind wearing glasses even afterwards also. They don't feel also. Always you should tell the benefits and risk of further intervention also important. So again, the correcting the refractive surplus depending upon the surgeon's comfort, then how long the lens has been implanted. Of course, the retained viscoelastic, sometimes he can do a early laser eye capsulotomy that allow the anterior displaced IOL to move posteriorly. Corneal refractive surgery we have been training, but always not do before 3 months. Give the eye to settle down. So best option is PRK or someone with the Visumax platform, which can give a lesser pressure on the eye. You can even think about flap, femto flap. Then for you can think, because if you do with the flap, always you can have an option for re-enhancement. So a lot of options been we tried with the wavefront guided treatment, which is the better outcome than the topo guided treatment according to some of the studies. So always LASIK is safer patient if you do already previous YAG capsulotomy. So limitation for laser vision correction, normally with the high refractive error, low corneal stromal thickness, and of course extra cost. We have been trying out with this with the piggyback lenses. So the advantage, when you put a piggyback lenses, you need not have to alter the corneal shape and do not change the corneal refractive power. So you don't require, because you know that to have a refractive machines, only me or Jaram can put the machine, but some other people, to have refractive machines itself is so expensive. So in such case, I think this add-on circoplex lens really gives a very good results. So always you should tell the patient the risk of these piggyback lenses also, because sometimes all these lenses can have a pigmented dispersion also. Then extra cost for the lens you have to bear, because it's a bit expensive. This is a one more sulcoplex lenses. Some of the patient after operating monofocal lens, they come to us. Do you have any option? I don't want to wear the glasses. In such cases, we have tried with this kind of sulcoplex trifocal lens, which really gives a very good results. So Naurosh was already mentioning about the dry eye workup. So you have to always, all premium patients, you have to do a very good dry eye workup, but post-operatively patient can come back to us with a dry eye. So what we do actually, patient with a very severe dry eye, they come to us. We do with like with the moderate severe dry eye, we do the highlight treatment. We start them on cyclosporin, especially the higher concentration cyclosporin like Sequa. We start them 15 days before, then we call the patient for surgery. Even after the surgery, we continue them for a period of 3 to 6 months. Patient will be very happy. Of course, patient, of course, always we have to treat the dry eye. I am not talking much about that, already Navras told. But we know that it's a multifactorial disease. You need to approach multifactorial approach, and you have to resolve the inflammation too. So normally treat with the topical corticosteroid, cyclosporin. We have been trying and giving good results. We combine sometimes nowadays with the patient when they come to us. They might be having a 6/6 vision. They'll tell, I am having a one peculiar pain, doctor. Somehow I could not able to tolerate. This is the one complaint everybody, somewhere pricking. But we have started trying out this lifty grasp and started giving a fantastic result post-op. I think you should see on that. Then of course we have been, those are with the some lid margin difficulties, I think you should go with the doxycycline. So these are the different modules. Always the lot of studies has been showed by Narayan Netralaya. All this lubricating with the amount of Trialose combination, that will have an anti-inflammatory effect, that will take care about the dry eye problem. Of course, these are the one problem I think you need to address here post-op, still not a dysphotopsia. So patient may come to us, especially positive dysphotopsia in the form of glare, halos, starbursts and light streaks. Some of the patients come to us, I think we have been experienced something, a senior surgeon might have come with a negative dysphotopsia. So the typical complaint, patient come to you with a temporal dark shadow or crescent shaped peripheral sort of dimming. So these are the things I think you need to tackle them properly, especially for negative dysphotopsia. Not much treatment. Even we have done some of the patient lens exchange also. You need to go for a, sometimes square edge lenses also can cause us in such case, because dysphotopsia itself is a one big full presentation I'm having in my laptop, but that will take around 15 minutes. So you need to think about what kind of lens you use to. Some of the patients, sometimes round edge lenses really have a less photopsia compared to the square edge lens. So these are the problem. I think you need to look at the IOL design, material, high refractive and pupil size and lens position. Often improve over the time. When brain adapts, you should give them the reassurance, very, very important. Sometimes if persistent, you can go ahead with the eyeglasses, changing the IOL type. Reverse optic capture also, people been tried, good results. In worst cases, I think you have to do the IOL exchange. So I think IOL dislocation, whenever you are having, I think few of them I have seen, few of my colleagues, when you put a inject a lens, I think lower haptic has been cut. You try to position it, patient will come to you after a couple of weeks that the entire lens don't do like this. Nowadays you will get a very good IOL cutting forceps. I think Diksha, do my friend Neha has designed such a beautiful IOL cutting forceps which can plug into the phaco machine. You can cut it like a butter within the eye, cut into 3 pieces, you can take out, and in the same setting only you can put the other lens, that gives a better result. So whenever you are having IOL dislocation, you see, I think you have to remove and you should put a better lens. So I will not talking about. So what are the future directions? As Jairam said, that use of femtosecond cataract surgery perform a key cataract surgery, step for high precision. If you want a high precision, I think femto, because some of the patient come to me, they want very next day 6 and 5. I do femto, and whenever if they are having even 0.37 cylinder also, I put LRIs. So that makes next day 6 wow effect. Put them LRIs. I know that these LRIs after a couple of years, the patient may come back to the some astigma, but immediate effect 6 and 6. Of course, for precision femto definitely have a better results. Create corneal incision, capsulotomy, lens fragmentation with the laser guidance with the femto. It improves the centering and capsulotomy for better for IL position. Very very important. Of course, that reduces the fake energy needed pre-fragmentation of the lens. Potential benefits enhance precision, faster recovery, but limitation higher cost we know. So other thing is better biometrics for cataract surgery, hydrophobic acryl IOL, there is a lower risk of PCO, good optical clarity, square edge IOL design, mechanically reduces cell epithelial cell migration that lowers the PCO rate, enhanced biocompatible acrylics minimize the inflammation, fibrosis and capsular contraction. We have been using this heparin surface modified IOL that will reduce the postoperative inflammation. Glistening free acrylic material improves the long-term clarity and reduce visual disturbance, which improved material, especially stable acrylic lens, maintain the centration and reduce the IOL tilt or decentration. Blue light filtering material may reduce the glare and dysphotops in selected patient. Conclusion, better precautions in pre-op screening and immediate post-operative period saves the vision. Laser vision correction has shown a viable, non-invasive and accurate procedure for correct amyotropy after cataract surgery with IOL implantation. Lens-based procedure like a piggyback lenses are the possible alternatives. Piggyback IOLs technically easier, more accurate than IOL exchange. Improving outcome and patient satisfaction is a must. I thank the entire KSOS for this opportunity. Thank you, Anand.
It was a excellent talk. So in just to have one or two questions for discussion regarding post refractive surgery patients, which IOL do you prefer, and what is the because they have usually spherical aberration will be changed, corneal shape will be changed, higher order aberrations.
Yeah, post refractive surgery normally we don't before we never used to put them multifocals or patient with ring lenses, but now the advent of all these newer EDOF or advanced monofocals, I feel advanced monofocal by doing micro monovision, I personally feel better. But again, you need to work up the patient even post refractive surgery. After pentacam, after eye trace, you calculate how much is the internal aberration. Then you decide. Sometimes even post refractive surgery also ring lenses you can still put. Again, depending upon how is the overall post-op outcomes, then you can take a call on that. But most safer. Not everybody will have eye trace. Not everybody will have pentacam. But okay, which is the best one? Someone comes. I think if the patient want a premium lens, much safer is advanced monofocal. So best is, I think you had already showed one of your slide. Patient, if they are undergone already refractive procedure for myopia, whether it is smile or whether with the LASIK. So either these kind of lenses, as Diksha said, that Rayner, that will do quite well with the patient. Those are already done with the hyperopic classic. But those who are already undergone, I am giving the example, those are already undergone myopic classic, my preferred lens will be probably from Hoya, which is like the Hoya advanced monofocals. I think Vivinex. Those lenses really do well. And we have been also trying with some of the lenses from Indian make, especially from Biotech. So excellent lenses, EDOF lenses. The results are much better than any of the imported lenses. Again, we need to look at what kind of refractive procedure they are undergone before. Depending upon that, then we have to select the lens.
Any take on this pediatric patients, sir? Do you prefer multifocal or?
Pediatric patient, depending upon the age, actually we need to see. Um, to have like achieve a good to treat a kind of amblyopia, we have been uh, trying with this. Initially we started with a multifocal, but you know, no, all this multifocal when you implant at the age of 10 or 12, suddenly the if eyeball start growing, then suddenly the baby might be having a very much residual error. So I think pediatric patient, younger patient, better to avoid this. Go with the monofocal. Later on, we'll have an option for them to have a this kind of any of the laser refractive surgeries. So for if they're having, say one of the baby had come to me having a residual error for around the age of 14. They came to me of around the age of 20-25 now having a refractive error of right eye around 2.5 and left eye around 4. I did press band for them. Then patient, the boy, he was around 22 years I did. He is very happy, having a good vision for distance and having a good vision for near. So again, type of refractor, better to avoid multifocal lens in the pediatric patient.